Right, so bidirectional integration to improve the health of people with severe and persistent mental illness. Integrated care. We know that integrated care is the systemic linkage of mental health and primary care. When we talk about integrated care in this context, it's the linkage between mental health and primary care providers that requires communication, coordination, so that we're doing a comprehensive health, comprehensive health assessment and addressing the comprehensive health needs of the patient, no matter where it is that they seek their care. Globally integrated care definitions can include the integration of health and social services, primary and tertiary care, preventive and curative health interventions, person-centered and provider-driven care, general health and behavioral health. You'll see a lot of different definitions, and you'll typically see terms like primary care integration, which refers to integrated care that's based within the primary care setting. And then sometimes you'll see reverse integration, which is a term that I really hate because it's insinuating that it's not the correct way. But reverse integration usually refers to bringing primary care into the mental health setting. What I would much prefer is to look at things from a bidirectional approach. So wherever the patients are presenting, that's where we want to meet them. So why integrate primary and mental health care? We'll just do a little bit of overview on some of the stats. So before the pandemic, about 1 in 5 Americans were experiencing a mental illness. We know that this has gone up during the pandemic, and that even people who don't necessarily qualify for a diagnosis are seeing higher rates of depression, anxiety, and obsessive compulsive disorder types of symptoms. In Ohio, we rank 34th in the country in terms of prevalence of mental illness. And the higher the number, the worse, the more prevalent mental illness is. The lifetime prevalence of any anxiety disorder is about 31%. Percent of US adults with major depression is estimated to be about 7%. Percent of youth with major depression is estimated to be at 13%. A lifetime prevalence of bipolar disorder, so experiencing bipolar disorder at some point in your life, is an estimated 2.5%. PTSD, anybody from 13 years and older, it's about 5.7%, and percent of US adults with schizophrenia is around 1%. A good number of these people will meet the criteria for a diagnosable mental health condition before the age of 14. So people are actually experiencing symptoms fairly early. Oh, sorry, went in the wrong direction. Goodness gracious, my slides today. Okay. And access to care is an issue. So if we have all of these people experiencing mental health conditions, we need to be able to provide them access. And access to care is a major problem, particularly for mental health care. So Ohio ranks 37th in healthcare nationally. So that's all healthcare, not specifically mental health. Over half of adults with a mental illness do not receive the needed treatment, which totals over 2.7 million adults in the US. The percentage of adults with a mental illness who report an unmet need has increased every year since 2011. Over 60% of youth with a major depressive disorder do not receive any mental health treatment. And even in the states with the greatest access, nearly 1 in 3 go without. Ohio ranks 22nd in access to care. So the higher the number, the less access. So we're not doing as bad as all the states. But estimates indicate about 40% of those who receive treatment do so from a primary care provider. So that's one important reason to look at mental health integration within primary care. And although 60 to 80% of all primary care visits include some type of a behavioral health component, part of the unmet need for services is a lack of providers who are willing or feel competent in treating such conditions. So many providers may screen and diagnose and treat some very mild conditions. They often report feeling overwhelmed and ill-equipped to meet more extreme mental health needs. So looking at how the state is doing in terms of outcomes, you can see that Portage County ranks 23rd out of the 88 counties for health outcomes, where Summit ranks 44th. So there are just some basic indicators that you can see here. So poor or fair health, that's 17% of the county is reporting that. Poor physical health days, nearly 4. Poor mental health days, nearly 5. Low birth weight, physical distress, mental distress. So it's certainly, We're not doing as good as we could in terms of health outcomes. Certainly not the worst in the state, but areas for improvement. Some health factors. And so these are things that are important to look at because it's going to what will contribute towards our health outcomes. Portage County is actually doing pretty good with health factors, where Summit County is not so great. Still better than a lot. 32 out of 88 is not bad. You can see the ratios here between primary care physicians and their patients. So over 2,500 patients to one primary care physician in Portage County. Mental health providers, you're looking at 460 patients to one mental health provider. And that mental health provider is kind of grabbing the large swath of mental health providers. Percentage of children in poverty is high, adult smoking, physical activity, and obesity. So all things to take into consideration when we're looking at the overall health and well-being mentally and physically for our communities and for our patient populations. Benefits of an integrated approach to care. It's person-centered. Anytime that you're going at care from a person-centered fashion, that's going to be better care for that individual. It helps to achieve the quadruple aim. So it does improve population health. It improves patient satisfaction, provider satisfaction, and reduces costs. And there's a newly proposed quintuple aim. I don't know how far that will go, but I just recently saw an article about it, which is about trying to advance health equity. And what we talked about actually back in September of 2020 in one of our journal clubs is that we can see that integrated care can improve health equity. So collaborative care, particularly when there's a culturally centered care put in with that, can improve engagement, access to care, and quality of care for otherwise marginalized populations. So ideally, integrated care would be a bi-directional approach. So having that care having mental health care in the primary care setting, having physical health care within the mental health setting, being able to approach people wherever they are. But integrated care looks very different depending on where you are, and there's lots of different ways to approach it. So this is an old model. So it's the 4-quadrant model of clinical integration, and it tries to specify between the risk and complexity in patients, and then of the mental health, and then the risk and complexity of their physical health. Now, several years ago, I actually decided that this was not a very helpful quadrant to look at. Lots of words, not very explanatory. So I expanded on it and kind of created my own. And you can see in each of the 4 quadrants, it looks a little bit different. So in like quadrant 4, where you have high mental health need, high physical health need, you would want a truly integrated practice with specialty teams and intense collaboration. Something that you'd see between maybe a FQHC and community mental health center, or primary care and community mental health, all integrated within the same system. That would be your highest level integration, because there's high needs for those patients. Where high physical complexity but low mental health complexity, you might be able to handle all of that in a traditional collaborative care model within a primary care setting. Versus quadrant 2, where you see that there's high mental health needs but low physical health needs. That's when we start looking at that, kind of that reverse co-location, where you want there to be more of the physical health needs addressed within the community mental health center, because that's really kind of more that patient's health home would be in the community mental health center. And because the US is the way that it is, what we have is really a continuum of physical and mental health integration, from the lowest end, where you've got minimal collaboration. Maybe you do some universal screening. If you're really lucky, you have somebody who's a friend, on the opposite side. If you're in mental health, somebody who's in primary care that you can text with a question, or vice versa. The farther you get to the right is getting you closer to a fully integrated practice. Along that whole spectrum, you're going to see a lot of variation. So something that's been proposed is kind of this, and it's a little bit hard to read on the screen, so I'll make sure that we'll make sure that you get a copy of all the slides, and in them there are links to all of the publications and the resources that I use, so you can see it a little bit more in depth. But key components of integrated care within all of these areas are going to be screening, referral, making sure that you're actually tracking said referrals, ongoing case management, care management, and information tracking and exchange. And along that continuum, it looks a little bit different. So from no sharing of treatment information to having a shared registry and electronic health system, shared care plans. So bi-directional integration. It looks a little bit, it's kind of an interesting thing because it looks different, again, depending on your organization. So what some of the research has shown is that in primary care organizations, mental health professionals tend to work within the collaborative care model. So they're doing some direct consultation with providers and patients, maybe a little bit of direct patient care, typically more on the brief side. They're doing some training for the primary care team. And the mental health conditions most commonly treated are anxiety and depression. Where in mental health settings, primary care professionals tend to provide a lot of direct patient service, but then they require that ancillary support. So whether it's care coordinators, case managers, peer support workers, to really help maintain an active patient engagement and address all of the needs. And the mental health conditions seen there are mostly going to be bipolar disorder, schizophrenia, and more of the severe mental illness. And across both, you're seeing the same very common health conditions, so obesity, hypertension, asthma. But bidirectional integration can improve the health of people with severe mental illness. This is why it's super important, whether or not we're doing that treatment in the primary care setting or in the community mental health setting. Being able to do both of those in an integrated fashion does improve health for people with severe mental illness, which is important because people with severe mental illness do die from the same kinds of medical conditions, but tend to be younger in their life, that they're, so they're experiencing a shorter lifespan because of these health conditions. So mental health providers can play a central role in educating patients, helping them navigate, coordinate all sides of their treatment plans and what their treatment needs are. Certified peer support specialists and wellness groups can support self-management and teach them self-management skills. There's some literature that's showing that there's potential for psychiatrists to develop new roles within treating the medical conditions of their patients. So screening for things like medical conditions, screening for the metabolic side effects that you would expect with psychiatric medication, coordinating closely with medical providers, providing some medical services and medication, maybe when the patients don't have a primary medical provider, even things like starting a new medication, something like metformin, or starting something to treat high blood pressure or diabetes while you get them into a medical provider. And the decisions about specific treatments should be individualized and include a number of factors. So the acuity and severity of the medical problem that's going on, the patient's access to primary care, the psychiatrist's medical training and permissible scope of practice. So one of the things that Mark Munetz, our former chair of psychiatry, used to say is that he thought for young psychiatrists, the idea of adding more of a medical practice into their scope of work made a lot of sense because they still are kind of in a training process, and we could do more of that within residency, and then have psychiatrists coming out that are more comfortable prescribing typical physical meds. Whereas for himself, he thought he was far enough away from his training that he wouldn't have been comfortable doing that himself, which I understand. You also have to consider the capacity of mental health organization to provide medical care and what the patient's preferences are. So some positive outcomes that can be seen from integrated care models in outpatient mental health settings. So the integrated care models in outpatient mental health settings could be, you see a variety of things, but there's the ones that are referenced typically in the literature are some of the SAMHSA grantees from the Primary Behavioral Health Integration Grant Program, or PBHCI. So there was a bunch of grants and they've done some evaluation on that. There's also certified community behavioral health centers who have started to do more physical health services within them, and there's some data around that. But what we see is that by providing primary care within the mental health setting, and this is not universal because all of the models are kind of implemented just a little bit different, and there's some challenges with fidelity to models. So the data can be a little bit all over the place, but what we know can happen is increased access to primary care and utilization of primary care, reduction in emergency department visits, increased receipt of preventive health services, more screening and monitoring of physical health condition, improved monitoring of metabolic side effects of psychiatric medications, and a reduction in cardiometabolic risk factors. You also see an increase in things like foot exams for people with diabetes, increased screening for colorectal cancer, alcohol misuse, lipids, BMI, blood pressure, breast cancer, prostate cancer, tobacco use. And you do see some improvements in blood pressure, weight, BMI, triglycerides. So it can be very beneficial and we can get very positive outcomes. So some low-hanging fruit, kind of high reward ideas for places that are just trying to do more. Doing universal screening for both physical and mental health risk factors. Monitoring and treatment of metabolic side effects. So there's clear evidence that these are not very often provided to patients for whom they're indicated, but the services are arguably one of the easiest things for primary care improvement within a mental health setting. Utilizing peer support and self-management skills. Health homes, so behavioral health homes, one other version of the primary care being provided in a mental health setting. Those that included elements of peer support and self-management skill training showed actually the greatest reduction in cardiometabolic risk factors. Utilizing telehealth technology. We know that we can't necessarily have a full in-house team, and co-location isn't always possible, even if it's the ideal. So having some kind of a partnership where you can get on Zoom or whatever other telehealth platform and still do a warm handoff electronically. Intentional teamwork. So teamwork is a big piece of this, and particularly when you're talking about combining primary care and mental health care, those are two different cultures in terms of the way that they work. And so trying to make a point of those teams working together efficiently, knowing whose roles and responsibilities, what things are, having good plans in place, taking the time to build that team are all really important. Cultural humility, not only with the patients so that you're coming at them from a culturally responsive place, but cultural humility with one another. Again, the culture between mental health and primary care is often very different and takes some time for us to understand that. So being humble and approaching that from a safe, open kind of view. And social care. There are so many things within the world of social determinants and social vulnerability that will impact both physical and mental health care. And if we don't address, we can't actually improve the physical or mental health of the patients. So trying to take into consideration that broader spectrum of social care and social determinants of health. A couple slides with references.